And welcome to this webinar, this community webinar series this evening. We're delighted to have you here, and we'll just give a quiet moment whilst we allow for more people to join us, and I'll get us started in just a moment. My name's Claire Kelly, and I work on the team at Melanoma Patients Australia. And thank you for joining us this evening. So I think we will get started promptly because we have quite a lot to get through this evening and some incredible speakers to share their expertise with you. This evening, we're going to be sharing a webinar entitled Understanding Endocrine Side Effects of Immunotherapy. And as I mentioned, I'm Claire from Melanoma Patients Australia, and it really is I'm delighted and privileged to be here to do this session this evening, to facilitate this session tonight. Before we begin this evening's session, I would like to acknowledge the traditional custodians of the lands on which we are all meeting. I personally am on the land of the Gubbi people, and I wish on all of our behalves to pay my respects to elders past and present. And I also extend that respect to any Aboriginal and Torres Strait Islanders who are joining us today. Now, before we begin, we do have some housekeeping guidance to share for this webinar.
Sorry, Claire, just 1 second.
Sure.
We can't see your screen at the moment.
You can't see my screen.
Just let me know if you would like me to share your screen.
I think that would be great rather than me mess around with it.
Sure.
Thank you. I'm on before the housekeeping slides.
1 moment.
I apologise, everybody, for the fact that you can't see my screen, my slides. We will just get them up for you in a second.
Okay, they're good to go now.
Okay. Well, we'll get to back to what I was just sharing about the housekeeping guidance, and I apologise for that. So please be mindful that this webinar is being recorded, and it will be uploaded onto the Melanoma Patients Australia and the Melanoma Institute Australia websites in the coming days. Now, we do have an opportunity for questions at the end, and we ask that you would type those into the platform using the Q&A button, and we'll endeavour to get to as many questions as we can at the end of the evening. Please be mindful that we can't answer any personal medical related questions that are of a personal nature. So if you're asking questions, please ensure that they are of a general nature only. And the last bit of housekeeping is just to advise that once you come out of the webinar this evening, you will see a brief survey pop up. And we're really grateful if you could please complete that survey after the webinar so that we can ensure that we continue to provide meaningful and valuable content for you. Okay, on to the next slide. I'm assuming it's there. Tonight's session is the second in a series of 3 webinars, both brought to you by MIA and MPA. Last week, we explored Your Melanoma Nurse, what they do and how they help, and that recording is now available online. Tonight's webinar is a really important topic where we'll be talking about understanding the endocrine side effects of immunotherapy. And for our final webinar next week, we'll be talking about understanding sentinel node biopsies and helping patients to decide decide around having a sentinel node biopsy. We'd love for you to join us next week for our final webinar in the series, but please do note that you have to register for each webinar individually. So you could do that through this QR code here, or you can go to either of the websites of Melanoma Patients Australia or the Melanoma Institute of Australia. Okay, without further ado, I would like to introduce our speakers. So we have four incredible speakers this evening, and we're really privileged to have each and every one of our speakers. And I'm going to just introduce them all at the beginning so that we can keep the content seamless as we go through each presentation. Our first speaker is Dr. Stephanie Zunder, and she's a medical oncologist from the Netherlands with a dedicated focus on melanoma care. Since 2025, Stephanie has been part of the melanoma team at Erasmus Medical Centre in Rotterdam. And in February 2026, she started a one-year fellowship at Melanoma Institute Australia to further develop her clinical and research expertise in immuno-oncology. I hope you're loving being in Australia, Stephanie. Our next speaker will be Dr. Annabelle Hayes. And Annabelle is an endocrinologist with both clinical and research interests in the pituitary gland. Since completing her pituitary fellowship at St. Vincent's Hospital in Sydney, Annabelle has continued pituitary research through her PhD studies into underactive pituitary following immune checkpoint inhibitor therapy in cancer patients. And she's been doing those studies at the Colling Institute at the University of Sydney. Annabelle is a conjoint clinical lecturer at the University of New South Wales, and she mentors trainees through the International Pituitary Society's preceptorship course for fellows. Our third speaker this evening is Aled. Aled Gaynor is a clinical nurse consultant at Melanoma Institute Australia, and he has more than 8 years' experience in oncology nursing. Before joining MIA in 2023, Aled worked in inpatient care at the Royal North Shore Hospital. He holds a graduate certificate in cancer nursing from the Australian College of Nursing and is passionate about supporting patients throughout their melanoma journey. And we're delighted to welcome our community member and patient speaker, Carmel, this evening. Carmel Finnegan is a melanoma patient from Townsville in Queensland, and she's been living with stage 4 melanoma since 2016, and we're pleased to share is currently NED, no evidence of disease. Carmel is a former school teacher, and she now runs her own education business, supporting students with learning differences. And she joins us today, and we're so grateful for her acceptance to share her own experience of living with melanoma and specifically the side effects of the immunotherapy that she had. So I'm so looking forward to this session. It's something that we get a lot of phone calls and support needs expressed for this very topic from our patient community. And I'm sure it'll be of interest to everybody attending, both patients and professionals alike. So with that, I'm going to hand over to our first speaker, Dr. Stephanie Zunder. Thank you, Stephanie.
Well, thank you so much for the kind introduction, Claire. I'm just going to share my screen. Okay. So thank you everybody for joining tonight. We have a lot to cover during my 10-minute presentation. We'll focus today on to start off with how immunotherapy works, how we monitor these endocrine side effects as your medical oncology team, and which symptoms we're aware of when we're seeing you during your clinic visits. So just to start off with how immunotherapy works, in your immune system, you have natural checkpoints. You could compare these to a safety brake that stop your immune system from getting too strong and harm your healthy cells. When you're looking at the top image, you can see an immune cell, a T cell, and then the green circle is the checkpoint, which is actually locked and holding back the immune cell from targeting the tumor cell, which enables the tumor cells to survive. This is something that we want to disable. And here's where our drugs come in, our checkpoint inhibitors. So with the checkpoint inhibitors, the immunotherapy, we actually unlock the brake on your immune system in order to make the T cells of your immune system recognize the tumor cell and attack and destroy it. So with immunotherapy, we're actually upregulating your immune system. And it's important for patients and family to realize that this is a different principle than with chemotherapy. So you're not more prone to getting infections with immunotherapy because actually your immune system is activated. Which drugs are then considered immunotherapy or also checkpoint inhibitors, names you might have heard about during your visits in clinic. For instance, we have ipilimumab, which is most often combined with nivolumab. In addition to that, we also have pembrolizumab, cemiplimab, and relatlimab. These are all checkpoint inhibitors, all considered immunotherapy, but they just target a different part of the immune system. But the mechanism remains the same. Immunotherapy is currently the standard of care for melanoma and also a lot of non-melanoma skin cancers, but it's also being widely used in other types of cancers. In those cases, it's most often combined with chemotherapy. So why do side effects happen? As I just mentioned, with immunotherapy, we're actually boosting your immune system, activating your immune system, and sometimes the immune system can overshoot its target and recognize innocent cells in your body as an enemy. Because your immune system is throughout your whole body, in theory, anything can get inflamed, and we call these immune-related side effects. As you can see on the image on the right side of your screen, almost everything is marked and could potentially be or get inflamed by the immunotherapy. But for tonight's session, we're only going to focus on the 4 hormone-producing organs, which are most commonly affected by immunotherapy. And I also have to mention that these are actually the only side effects that are not reversible. So we'll be focusing on the thyroid gland, the pituitary and adrenal glands, and the pancreas. So very briefly, I won't get into too much detail, but in the normal circumstances, we have hormone axis. So on the left side of your screen is actually the pituitary and thyroid axis. It starts with at the top part with in your brain, a region which is called the hypothalamus, which gives a signal to your pituitary gland. That's a very small organ localized underneath the brain. The pituitary gland then signals to your thyroid, and your thyroid then gets the signal to produce thyroid hormone. Once there's thyroid hormone in your bloodstream, it feeds back to the system and says, okay, we have enough thyroid hormone, or up the production a little bit. On the right side of your screen, you'll see the pituitary and adrenal axis. And the adrenal glands are small organs localized on top of your kidneys who produce your natural stress hormone, also called cortisol. Again, the system works with a region within your brain, the hypothalamus, which gives the signal to the adrenal gland, to the pituitary gland, and the pituitary gland then gives a signal to the adrenal glands to produce cortisol. And also here you have the feedback loop. If there's enough cortisol in your system, it feedbacks to the pituitary gland and the hypothalamus to say, okay, we have enough hormone. But you could imagine that if either that pituitary gland or the thyroid or adrenal gland gets inflamed and stops working, the whole system is off balance. And that is what happens with, or what can happen with immunotherapy. So how do we monitor for side effects during your treatment? We ask you, as a medical team, we can ask you different questions during every visit to see how you're feeling and see if there are any inclinations of a side effect occurring. Prior to every visit, every cycle of treatment, we do regular blood tests to monitor for possible side effects. And especially in the beginning of your treatment, we have a closer eye on what's going on because we know that most side effects usually occur in the first months after starting your treatment. With regard to the blood test, what do we monitor? Well, to monitor the thyroid function, we test for your TSH and T4 level in your blood. To monitor the pituitary and adrenal gland, we monitor the cortisol level in your blood. And to monitor your pancreas, we look at glucose, amylase, and lipase. So to start off with the thyroid changes, the thyroid changes are the most common side effects which we see regarding the endocrine side effects. Almost 10 to 20% of patients can get a disturbance in their thyroid function due to treatment with immunotherapy. This is a range though, because you can imagine that if you are being treated with 2 types of immunotherapy, the odds of developing a side effect are a bit higher. That's why it ranges from 10 to 20%. It usually happens within the first 3 months of treatment. And in the early phase, when the inflammation is active, we actually see that there are high levels of thyroid hormone in your blood. Your thyroid gets inflamed and releases all of its storage of thyroid hormone. We monitor your blood, and then in the later phase, most often we see that the thyroid stops working and you become hypothyroid. What are the symptoms then that are accompanied with these disturbances? With the hyperthyroidism, so an overly active thyroid, the metabolism actually gets activated. So what we usually see is that the heart rate can go up, patients can have fatigue, weight loss, diarrhea, insomnia, sweating or tremors, also irritability, and in women, menstrual changes. When the thyroid finally, the inflammation finally settles and the thyroid is working too slow, the metabolism slows down as well. What we then often see is that the heart rate gets lowered, fatigue, weight gain, intolerance to cold, constipation, joint pains, depression, hair loss, and menstrual changes. Usually, the transition from hyper to hypothyroidism is within a couple of weeks to a few months, and we keep monitoring your blood work to see where you are at in this change which occurs. Then going to the pituitary and adrenal glands. So inflammation of the pituitary gland, we call that a hypophysitis, and this occurs again a range from 1 to 10% of patients, usually in the first 6 months of treatment. An inflammation of solely the adrenal glands occurs in approximately 1 to 5% of patients, and the onset varies. It can be days to over 12 months. When the pituitary and adrenal gland dysfunction, you have low levels of cortisol, low levels of your natural stress hormone. And this could be accompanied by symptoms like dizziness, gastrointestinal symptoms, fatigue, headaches, and feeling generally unwell or weak. The last endocrine organ which can get affected by immunotherapy is the pancreas. The pancreas is an organ which is involved in your digestion and is critical for the production of insulin. And insulin is necessary to regulate your blood glucose levels. Approximately 1% of patients get an inflammation of the pancreas, which leads to destruction of the insulin producing cells, and eventually it leads to type 1 diabetes. This most often occurs early after the 2 to 5 cycles of treatment, and a simple blood test showing a high glucose level is usually how it's noticed initially. What are the symptoms of a high glucose level or type 1 diabetes? People get thirsty, general weakness or unwellness, dizziness, blurry vision, weight loss, a lot of hunger, and also frequent urination. So we've now discussed the 4 endocrine side effects which can occur and the symptoms which they are accompanied with. Then I'll hand over the presentation to Dr. Annabelle Hayes to discuss the treatment of these endocrine disorders.
Beautiful. Thank you so much, Stephanie. That was a great presentation. Doesn't seem like I'm sharing the right screen just yet. So can everyone see this one? Claire?
Lovely. That's great. We've got that.
Excellent.
Thank you.
Beautiful. So without further ado, I'll continue. We've heard about the symptoms and some of the tests that would do for endocrine side effects. So I'll lean more into the treatment and how your relationship with your endocrinologist will probably go back and forth. It's not always linear between tests and treatment. And as Stephanie said, a lot of these side effects, almost all of them are permanent. And so we, as endocrinologists, we get to know you very well. So to start with the thyroid, as Stephanie said, the thyroid axis, which is just across to the right there, starts at the pituitary gland, the master hormone gland, and that makes TSH, or thyroid stimulating hormone. And that does what it says on the packet, really. It stimulates your thyroid to make thyroid hormone, most of which will be T3 and T4. Or, sorry, most of which will be T4, a little bit of it will be T3, and they swim around your body and control some of your metabolism. And the pituitary gland senses that and the hypothalamus, and they say, oh, don't worry, we've got enough. So the TSH and the T3 and T4 all sit in a nice balance. So we start off the story here with a nice equilibrium When these immune cells come along and they get activated, if they do attack the thyroid, you get an uptick in your thyroid hormone. So your thyroid releases more thyroid hormone, and that's when you start to feel a bit hot, sometimes shaky. Your mind can race, it can be difficult to sleep, and that shuts off that signal to make more thyroid stimulating hormone. So then we see a downtick through this slope as your thyroid hormone level comes back to normal. But over time, these immune cells have actually killed off, destroyed your thyroid, which is your thyroid hormone factory. So you can't produce as much T4 and T3 as you could before, even if your pituitary gland tries really hard to squeeze as much as possible out of it. So we have that low thyroid level afterwards. So starting with the treatment of the overactive or hyperthyroidism, we find that out with your symptoms, which we talked about before. And on a blood test, we measure all those hormones, TSH, T3, and T4, as well as your thyroid antibodies, because sometimes they can be helpful. The main focus for most people with overactive thyroid disease here is actually just watching your symptoms. So some people have more pronounced symptoms than others, and if you need it, they might be controlled on a beta blocker, which is usually propranolol that we use. Very rarely, and depending on your individual circumstances, your endocrinologist might also use an anti-inflammatory like prednisone or carbimazole, which blocks the thyroid production. Most of the management here is actually just watching and waiting to see that transition into the underactive stage, the hypothyroidism, and that's going to be with blood tests and watching your symptoms. So again, we pick that up on the blood tests. That can happen usually weeks to short months, anywhere between about 5 to 14 weeks since the onset. And when it does become underactive, we just replace it. So endocrine side effects may be permanent, but they're also very, very treatable. So these are conditions that are really common in the public, in the community. Trust me, if you ask your friends, you'll find somebody who is on lifelong thyroxine for a normal autoimmune thyroid condition. So levothyroxine is just a daily tablet. We take it on an empty stomach, 30 minutes before food and drink, and your other tablets, because that can interfere with the absorption. We titrate the dose, we adjust the dose to you and your body and your blood tests. Normally at the start, we measure it about every 6 to 8 weeks. And over time, you might become very stable and we only measure it a few times a year. So initially, every couple of months. Now moving on to the pituitary gland itself. So it's the master hormone gland that sits about the size of a pea just behind your eyes under your brain. And that controls lots of different hormones, but the one we're most concerned about here is your cortisol, which is your natural stress hormone. It gets a bit of a bad rap in social media, but we do all need some cortisol to stay alive. We need it for our cells to continue to metabolize. So the way we pick that up, again, would be the symptoms that we talked about earlier with Steph. And your blood tests. Now, it's important that we measure that in the morning. So we measure a cortisol and the hormone that stimulates it, which is ACTH. Now, the reason we measure it in the morning is because that's when it peaks and it falls throughout the day. If indeed it is low, then we replace the cortisol as the first priority before we think about the other hormones. And that will be often in the form of a prednisone tablet or a hydrocortisone tablet. Now, hydrocortisone doesn't last quite as long, so we have that in the morning and at lunchtime to mimic the usual distribution of your own cortisol. So we're just manually replacing a hormone that you'd be producing in your body. Now, after you've started that, it's likely that your endocrinologist will look at the rest of the pituitary function and do a full pituitary panel. That'll be another blood test. Again, it's done in the morning. It's a fasting blood test, and you take it before you have your medications. So we talked about cortisol replacement. Now that's the most critical. The other hormones that we might replace are then thyroxine, just as we would with thyroid disease. and sometimes also your gonadal hormones, so testosterone from men or estrogen and progesterone for women, particularly if they're before menopause. What's very important regarding cortisol replacement is what we call sick day plans. Now, stress dosing is when your body produces more cortisol in times of stress. So that's not just emotional stress, but it might be something like an infection, or if you're going for an operation, you need more cortisol to cover those demands of the body. So you'll get an education plan on stress dosing, Solu-Cortef, which is an injection of cortisol. That's essential to have. It's like having an EpiPen. If you had an anaphylaxis, unfortunately, it's a little bit trickier logistically than an EpiPen, but it is absolutely essential. And you have some education around that. And thirdly, it's a medic alert bracelet. So if anybody comes across you and you're not able to communicate that you need extra cortisol, they're able to tell that from your medic alert. Now, this can be quite a stressful condition to live with, but don't worry, we do have support, and we have a lot of people who have this condition before we had checkpoint inhibitors. So your first port of calls would be your local endocrine nurse. They're normally going to be in a tertiary hospital, in a major hospital, and also your endocrinologist. And they can do a lot of this education around it. And the next port of calls will actually be your patient-centered foundations. So your Australian Pituitary Foundation, that website I would thoroughly recommend. It has lots of great articles and education resources, as well as the Australian Addison's Disease Association. So strongly recommend having a look at both those sites and joining up. I'll put some links at the end of the slides. So every patient will get a sick day management plan. This is a standard one from our Endocrine Society of Australia. It has your details at the top, and importantly down the bottom, it has instructions on what to do depending on how sick you are. So if it's just a cough or a cold, and when to go to hospital. So this covers cortisol deficiency if it's from the pituitary gland or if it's directly from the adrenal gland, which is usually cortisol factories. So both. Now on the back, it's also got instructions for your anaesthetist around any sort of surgery or procedures. And thirdly, the last big complication that I'm going to discuss today is checkpoint inhibitor associated autoimmune diabetes, which is most similar to type 1 diabetes. So it's a case where you don't have enough insulin rather than you're making insulin and it's not working. Now, insulin's our hormone that controls blood sugar. So when you don't have enough insulin, your blood sugar goes high and you'll have those symptoms that Steph talked about before. Chances are you'll detect that on a blood test. HbA1c is a 3-monthly average blood glucose, so that might not be high to start with, but that's certainly something we'll be looking at over time. And to treat insulin deficiency, we replace the insulin. So we have 2 major types of insulin: long-acting, which is a slow-release insulin that's there all the time, and then short-acting, which covers times that you have extra glucose around your meals. Sometimes your endocrinologist will work in some other medications that we might normally use for type 2 diabetes, just to see if we can help the insulin work a little bit better. So these are the pens that we use for your insulin. The grey one's your long-acting, and the orange and blue one is short-acting mealtime insulin. In terms of monitoring, traditionally we monitored with finger pricks about 4 times a day, but these days we have these fabulous continuous glucose monitors. They measure your, without finger pricks, they measure your blood sugar every 5 minutes, almost blood sugar, the interstitial sugar every 5 minutes. And so you sort of restrict finger pricking to as needed, and that also might mean ketone monitoring, particularly if you're sick. Support here is through your local diabetes nurse educators. They might be from your local tertiary hospital, or even actually some of our smaller hospitals are now equipped with diabetes nurse educators. And they're a fabulous resource and can help you adjust your insulin doses around your needs and around what's happening at home. Of course, your endocrinologist and Diabetes Australia and the National Diabetes Services Scheme are fabulous resources there. So I've spoken a lot. There are a lot of details and lots to cover. But if you're going to take a screenshot of any of my slides today, this one would be it. And you can have a look at some of these fabulous foundations and resources. So I'll give you a couple of seconds to do that before I hand across to our amazing medical oncology clinical nurse, Aled.
Thank you so much, Annabelle. Those resources have been put in the chat as well, so please do head over to the chat and you'll be able to see links to those, each of those resources that Annabelle's kindly shared. And we will hand over to Aled. Thank you, Aled.
Thank you so much, Claire. And thank you to MPA for having me. I'm just sorting my computer out. My apologies, I'm a little bit husky. I'm just at the end of a cold, so I will do my best. And thank you to Annabelle and Stephanie for your fantastic presentations, making quite a complex topic accessible for those joining us today. Can everyone see my slides?
Yeah, they're good to go. Thank you, Aled. They're great.
Fantastic. As Steph has talked us through immunotherapy, how that works, and the symptoms and tests related to endocrinopathies, and Annabelle has talked us through the treatment of these endocrinopathies, I've got the task of focusing more on the education and assessment and support of patients throughout this process. So today I'll talk to you about the role of the specialist nurse in this scenario. I know that Rebecca spoke more extensively on this topic last week, so I'll be focusing on my own practice as an outpatient medical oncology nurse, but there are so many nurses that you might meet throughout this process, whether that's the diabetes specialist nurse or somebody on the ward, for example. An oncology specialist nurse, regardless of the tumor stream, is an advanced clinician with expertise in the treatment and management of patients undergoing cancer treatments. And we exist as part of this wider MDT that you've met here today. And I see my role being as a bit of an intermediary between the patient and the MDT outside of those clinic appointments. You'll see that nurses wear a lot of hats in these scenarios. And one of those is being the first point of contact. So where you can report any physical changes that you might be experiencing during treatment. Your nurse here is an investigator gathering objective and subjective data to feed back to the medical team to interpret, and then your nurse may act as a translator, relaying that information back to you from the team in an accessible way, ensuring that the patient understands and is able to follow the treatment plan. And this could be just as simple as getting a script from the doctors to a nearby pharmacy to collect for steroid replacement, or more complicated, such as educating a family or a loved one about sick day management, as Annabelle was just telling us about. Your nurse might be responsible for the initial education about the immunotherapy in the first instance, or about the interventions that we use for treating toxicities. I'll go more into this shortly. And finally, your nurse may primarily be involved in care coordination and ongoing support for those who have completed their initial cancer treatment and are living with potentially long-term consequences, such as these endocrinopathies described by Steph and Annabelle. The early detection of immunotherapy toxicities begins at that initial consultation and the initial education sessions. A patient who feels empowered and encouraged to report symptoms and know what to look for is a patient with better outcomes, as the treating team will be aware of any changes from their baseline, especially if the person is being cared for in the outpatient setting. No two patients will present with the same lived experience or knowledge of healthcare, so it's important to assess these levels of health literacy to ensure that our patients are able to understand and retain the key safety messages that the treating team is trying to convey. I like to incorporate adult learning principles, which are particularly patient-centered, with an emphasis on knowing the motivations, the pre-existing knowledge, and the experience of the learner when going through these education sessions. In my experience, the waiting room of a busy clinic or a shared 4-bedded bay might not be the most optimal space for patient education. So I like to consider a quiet space with minimal distractions where patients are able to focus and retain information. This is particularly important for elderly or neurodivergent patients who might have sensitivity to lighting or background noise. Assessing the patient's prior knowledge and experience prior to commencing their education helps us to understand the level of their health literacy and shapes the language that we use and the analogies that we use to convey our points. Such as utilizing different types of learners, so whether they're audio resources or visual learners. Regular and ongoing formal assessment with the treating team, whether it's over the phone or face-to-face, also detects these toxicities earlier and thus leads to best healthcare outcomes for patients. I often find that culturally it can be quite challenging here in Australia, where there is a tendency towards stoicism that, she'll be right, mate, oh, I don't want to bother the nurse or the doctors, can actually mean that we pick up on these toxicities later and leading to potentially sicker patients. So from those initial consultations, it's a bit of a challenge to break those cultural norms and explain to people it is so much easier to deal with issues when they're molehills rather than they're mountains. And also reassuring patients that you're never ever bothering your nurse. They want to hear from you. We want to help you. That's why we went into the field in the first place. In nursing, we might use a variety of formalized assessment tools that can vary from site to site, but primarily those assessment tools are standardized and we can grade these toxicities early. By utilizing a systematic approach, so whether that's from head to toe, or we use systems like we go through the respiratory system, we go through the GI system and the symptoms that are associated with those, allows us to pick up on clinical information that might be pivotal to an accurate diagnosis. It is important that we as nurses are able to engage in effective communication with our patients, and these needs can be assessed at that initial consultation, such as language barriers and then organizing subsequent translators. Or for those who might be hard of hearing or focus, being provided with alternative methods of communicating, such as email or text. And also just communicating in a plain, accessible language to ensure that our patients are able to comprehend what we're trying to portray. And finally, documenting these interactions to ensure continuity of care during periods of leave or role changes. Finally, the role of the nurse during survivorship when patients are living with endocrinopathies. As a nurse, I'm here as a resource to help you navigate the healthcare system, to translate it for you, to ensure the best level of engagement and your subsequent well-being. As Annabelle talked about earlier, an example of this might be the sick day management for those living with hypophysitis, to ensure that patients feel comfortable stress dosing during periods of illness or if they have procedures coming up, for example. And that also that families are involved in that process and loved ones, and they feel empowered to support them during these times and know when we can stress dose the medication or when we need to bring out the Solu injection or take people to an emergency department. As a nurse, we're also here to point patients in the right direction of support services outside of the healthcare sites, such as support services through MPA or the Cancer Council, the endocrine-specific foundations that were mentioned by Annabelle earlier, and also linking them to diabetic educators if they haven't already been by their endocrinologist and local nutritional services and dietitians. That's my presentation. Thank you very much. And I'm going to hand over to Carmel, who's going to tell us about her lived experience. Thank you, Carmel.
Hello, everybody. Thanks for having me on here. I'm just getting my PowerPoint up and going now. It's great to be here with everyone. Thank you to Aled and all the other speakers so far for the really valuable information. I'll start off just by sharing a little bit of my story, not too much. And when I started,
I'll just let you know,
sorry,
it's not in presenter mode at this stage.
I did forget that step. Right, that should be better. Yeah. So my name's Carmel and I'm from Townsville, and just before my diagnosis in 2016, I'd met my beautiful husband, Nick, and we were having a great old time. And of course, something on my left temple there was 5.5 mil deep. So I think that means into the bloodstream, and had the sentinel node biopsy. And then I think that meant left neck dissection in 2017. It was a bit harrowing. And I didn't feel like leaving the house. I was sort of that afraid. I didn't know how I was going to get well. And I'm very grateful to my dear friend Anne, who found MPA for me. So right from the very start, Anne and MPA and all my other friends have been there for me. And I wouldn't have got through this without them or the support of MPA. So I'm very grateful. And around that time, my friend Anne has a Groodle named Spark. And we just love Spark. So we got our own Groodle named Ruffy, and he's been a big part of my story along the way. So in about mid-2022, I had a brain tumor removed. It was a little bit of a surprise one. And so it left me with a quarter vision loss. So that's legally blind. So I was working at school, but I pivoted from doing that just because it's hard getting taxis to and from. And so just run my own little tutoring business now here at home. Just before that, I was taking Tafliner and Mechanist also. But after that, in about a little while after 2022, there was a little spot on my brain MRI. So I just had a little bit of gamma knife on that. And then it was just after that that it was decided that I'd start the immunotherapy. And there's the picture of me starting that there at our centre in Townsville. And before I go on, I'd just like to say that at that time, we didn't have our beautiful melanoma nurse who we have there now to support us. And also my oncologist, he was away also at that time as my side effects started. So it was a little bit tricky time, but got there in the end. So the side effects that started happening for me once I started the immunotherapy was a non-stop headache. It didn't leave me. It went on and on. I was doing aspirin and Panadol, anything else that I had in there that was okay to take, I suppose. Extreme light sensitivity, where I would have my sunglasses on even in the shower. Zero energy. So I'd say to my husband, can you just pull me around the house? It was that bad. Yeah, so zero energy, showering with sunglasses on even. Sort of sugar cravings, not like, oh, I want to have a tasty cake, so I've got a sugar craving. One where it was that I really needed it for my energy almost, because your limbs just feel like there's just nothing in them. Even if you wanted to move, you sort of can't. I've got nausea down there, so I must have had a little bit. Oh, yes, I did, because I was taking on Danzatron, which I usually don't take. But I also found that I think that helped with the pain of that headache, actually. And I think I got some tingling in the lips. I did go to ED a couple of times, twice to the private one, and one to like our other one. But I think these symptoms can be sort of really non-specific and maybe quite rare or quite an unknown thing that immunotherapy can cause these things. So sort of when I presented, I think it was quite the mystery. Though I was asking for ice blocks a lot, I think. And I think often it was thought that I had a migraine. So on 2 occasions, once another brain tumor was ruled out, of course, it was just recommended I'd go to the pharmacy and get some migraine tablets. And I suppose at the time I did feel a little bit, I don't know if the word's let down, but when I look back on it, it can take time to work out what these things are. I suppose things need to be ruled out or ruled in. And then I didn't realize that the cortisol test needs to be done at 8 a.m. in the morning. So of course, if I'm presenting at ED in the afternoon, then of course, I suppose how could they sort of test for that? I did take along my little form though a few times, but I think it's just so unknown. Yeah, that it was a little bit tricky. What else have I got here? Oh, yeah, just the importance of the self-advocacy. I think just to keep looking and to keep asking about, well, what could this be? Just get my thoughts here together. So then we had a look at a blood test, and I think it was seen on my blood test that I actually had hyperthyroidism. So I was given some thyroid tablets and I did start taking them, but I think they weren't helping because I still did present to ED after that. And then it just so happened lined up that I had an appointment with Dr. down south, and I must have in there somewhere had the appropriate blood tests because she let me know that yes, you've got hypothyroidism, but you've got zero cortisol too. So she said maybe it's time to hop off the thyroid tablets and they might burn them back. That might burn itself down, but you'll probably have to stay on something else for these adrenal or pituitary glands, maybe the Hysone. So I did start taking Hysone. I did leave a part of my story out just before I had that telehealth appointment with that other doctor interstate. That my GP helped me stop the headache, actually. She gave me a one-time dose of dexamethasone, and it just took that headache away so quickly. I was so grateful, but I was up all night, unfortunately, and then had to wean down off it. But I take the Hysone now, which has helped things so much. I still sometimes have to take a little bit more, which I'm getting used to. I'm not very good at it. I think, like Ali said, the patient has to stick to it or understand it'll be comfortable updosing. And because I'm so used to having it drilled in me that we want to be getting off medication, particularly if it came to painkillers, it has taken me a long time to be okay with the updosing. And I still do find it difficult. And I'm really glad my husband's around and my beautiful melanoma nurse to keep me on track with those things. I have found myself often, if I have needed to updose, on the floor in the kitchen, which is not like me. I eat very healthily with the Sara Lee carrot cake, just sitting on the floor, eating it in there. And now I know if I do that, I say, come, stop this, go get some more Hysone, and then the feeling or need for that isn't there anymore. Same for the frosty fruits, so that happens at probably a lower level need for the Hysone. And helping me along, of course, has been MPA because in the beginning I found this all quite difficult. I actually thought I was getting off the Hysone. I was definitely going to be getting off that and weaning off it, and it's taken me a while to realize that perhaps I won't. And so they have helped me in many ways emotionally, with other avenues I could go down. And they let me know about the Australian Addison's Disease Association. And so they help people who have these diagnoses, and we can join. It covers all forms of adrenal insufficiency, and it costs $35 per year to join. And you receive a fantastic information pack with lots of good information. There's 4 newsletters per year and a national seminar online. There's regular meetings for immunotherapy acquired people like myself and people that are probably watching tonight on Zoom, where we can catch up and chat about all this and make sense of what's happening. And it's mostly about education and encouraging each other. Yeah, and just being a part of that group also has helped me change the direction of my thinking about this whole condition and my approach to it, because at the start I probably wasn't the most proactive person, or as proactive as the association recommends. And so going to meetings, I was able to understand more about it, why I should take it so seriously. about the sick day dosing, why that's so important, even hearing about the injections, hearing about what can happen if there is an adrenal crisis, making sure that family and friends know about it. And as Alid said, making sure, do you have your maybe a bracelet, or is there a plan, which I don't have those things at the moment, but I am taking it more seriously now. And I think that might be, how I enjoy my life today. I do some tutoring. I love hanging out with my friends and my husband Nick, and hanging out with my dog Cyril and Ruffy. And I'm forever grateful to MPA and my friend Anne and all my friends here, the people who helped me at my centre. MPA has been helping me since 2016 in many ways, on the phone, about all sorts of topics, all sorts of subjects. I would recommend, anyone on any part of their journey to call up MPA, and they're there to help you to talk things through, maybe to get you going if you don't feel like going for your scan, or just things like that. They say, come on, book it in, or maybe you should, ring up about this or that, or just practical help. So thank you very much, everybody. Hopefully I've included everything.
Thank you so much, Carmel. That was fantastic, as were all of our speakers. And it's so good to get an insight from somebody that's actually, you've been living with the side effects of immunotherapy for quite some time. So there's a lot that we can learn from you as well, and we really appreciate you sharing your individual story with such clarity. I'm going to ask all the speakers to put their cameras on and their mics back on, because we have got a lot of questions. And we'll do our best to get to them. We'll try to keep responses succinct as we possibly can. But obviously it's a topic of great interest and of importance to many people. And I'm not going to labour on about why it's important we answer the questions. We'll just get on with them. And I'll start from the very beginning. But a huge thank you to everybody for sharing. And we've got a lot of questions, and I'm just going to start with them as they've come in. So the first question was, this might be, I'll let either Stephanie or Annabelle answer this, probably Stephanie. Does having multiple immune-related adverse events affect the long-term management or the outcomes of cancer outcomes?
No, not necessarily, especially when we're talking about these endocrine side effects. Usually during my consultations, I tell my patients that we as medical oncologists actually consider these endocrine side effects as a minor side effects, but with major consequences for our patient, because you're probably going to have to be on lifelong hormone supplement medication, but your immunotherapy can continue. So these are actually the only side effects which don't call for us to stop your therapy.
Okay.
I think even, I think that's such an exciting, well, not exciting, but such an important point, Stephanie. While we have to treat these side effects, and in Carmel's case, I wish we'd found out earlier and treated you earlier, because as an endocrinologist, hearing your story, it just broke my heart that it took so long to test a cortisol. But unfortunately, you're not the only person like that. And it can take a couple of trips to the emergency department. So if you do suspect you've got cortisol deficiency, use those words. See if you can say, I'm worried about my cortisol. Because that might even trigger a busy ED doctor's mind. And even if you can't test the cortisol that evening, you can receive hydrocortisone through the drip, and we can test it later.
Right.
The most important thing is that you get treatment.
Yeah.
So don't delay treatment thinking, I've got to wait for this blood test. We can do the blood test later. The most important thing is we start treatment.
Yeah.
Sometimes some of the immune side effects, some of the endocrine immune side effects can predict maybe a slightly stronger immune response. from your cancer therapy, but the major take-home message is that you can continue your immunotherapy.
Thank you, Annabelle. Great response to those questions. And I guess I'm just going to, echo what Alid said, which was, if you're at all concerned, as well as the great advice Annabelle gave about asking, telling the ED staff, what you're concerned about, is ring your nurse. If you do have a nurse, a melanoma nurse or a care coordinator supporting you, ring them to let them know. And they can always ring through to ED as well and give them an advance notification that one of their patients is coming in that's on treatment.
Absolutely.
The next question I have is, and I think we've kind of covered this, but is there somebody's asked, what are the common symptoms of a patient on the verge of an adrenal insufficiency crisis? Do we get a red flag of something happening? And I know you've spoken to the side effects, but is there something specific that somebody should be, when is the green light on and they need to go down to ED?
Red light.
Red light.
Unfortunately,
Well, yeah.
as Carmel sort of alluded to, all the symptoms are quite vague. So the most common symptom that we have is actually fatigue, but it will probably be more fatigue than what you're used to as a cancer patient. Nausea or a loss of appetite, headache, they're common symptoms. Unfortunately, starting the thyroxine before the cortisol might have used up that tiny little bit of cortisol that you had keeping you going, because thyroxine speeds things up. So we start cortisol first. But dizziness when you stand up, that's another one. And if you're starting to feel those, if you're feeling like you're well enough to stay home and you're just not quite sure if it's that or not, you can do a blood test the next morning and do a cortisol. But if you're feeling really unwell and you're on the couch and you can't get up, or you're really reaching for your sweets to try and keep your sugar up, just pop to ED or call an ambulance and say, I'm on immunotherapy. I'm worried about my cortisol.
Sure. Thank you for that. Somebody has been prescribed their thyroxine as a weekly dose because they're on plenty of medication, which they've been advised would interact with absorption. That happens.
It does. Yes, it does.
Practice.
So it's not our most common practice, but we do have certainly every hospital has a handful of patients at least. So the half-life, the thyroxine itself actually wears off very slowly. So that is a possible dosing mechanism in certain cases. So it does have, you might notice other effects from it, more of a high and a low, not quite as sort of smooth as a daily dose, but it is a very reasonable and very very well known to endocrinologists sort of technique to taking a thyroxine.
Right, thank you. Now, somebody's not heard of a sick day management, despite being on hydrocortisol. I know that you've talked about the support agencies. Would you suggest that somebody that hasn't been given that direction and I think it's important to note that not everybody has access to an endocrinologist necessarily that can go through this with them, or an endocrine nurse.
Endocrine nurses are sometimes quite hard to find in Australia, unfortunately. So they're not they're not very well funded. So, for example, even where I work in a tertiary hospital, we have funding for 1 day a week for an endocrine nurse. So that is unfortunately the sad reality. Everybody with cortisol, adrenal insufficiency, be that from the pituitary or the adrenals, should have a sick day management plan from their endocrinologist. That form that I showed up before, and I can do it again if you want, is a very standard form that we use from the Endocrine Society of Australia, developed by one of my lovely endocrine nurse nurses, Carmel Bischoff in Adelaide. It's essentially the nuts and bolts of it is you double or triple your dose. I'll just pop it up on the screen again, because it's, can I share, or is it too late?
I think you can share. We are almost done, but we'll keep going through the questions. I think it's in it. What we can do is we can put it in
You know what?
the
It's
in the
in
chat.
yeah, the Hormones Australia website, Addison's Foundation
Sure.
website, and also the Pituitary Foundation. But you double or triple your dose depending on how sick you are. So if you've got a fever, for example, you would be tripling your dose for at least 2 to 3 days until that illness has passed. So it might be that you might have a double or triple dose for about 5 days. If you cannot absorb, then the most important message is if you cannot absorb your hyoscine or your prednisone, whatever is your steroid, you need to receive it another way. So it needs to come from an injection, and that will be your Solicortef injection, which buys you a bit of time to get to the hospital to get it through the drip.
Yeah. Okay. It's so important, isn't it? Some of these issues are extremely critical, and we really, it just shows the importance of this topic and that people, need to get this information and get the support. Somebody else has asked, and I see that you've answered in the chat a question around managing a normal sick day, and that it is individual. So thank you for providing that response on the chat there, Annabelle, as well.
Sorry, Anna.
Oh, sorry. Yeah, no, Alan.
Just when you say not absorbing, just what do you mean by that?
Oh, sorry.
Just so
Yeah, I
we're
should be
jotting
more
it.
specific. That's a very good point. So if you've got like diarrhea or vomiting, say you've got gastro and nothing's really sticking inside you, it's coming out from either end, or you can't swallow your tablets, then that's a time to say, do you know what? I need some extra help. And sometimes diarrhea is actually a symptom of not enough cortisol as well. So that's something to keep in mind. You're not going to be a burden on anybody popping to hospital if you feel otherwise well, if you can't absorb. If you're vomiting or you've got diarrhea and you can't absorb your tablets, that is what hospital is for.
Great. I'm going to pop down to another question. Well, I'm going to ask, Aled, would you recommend a particular resource that outlines, or anybody that, what's the best resource around immunotherapy and the broad side effects of immunotherapy?
Oh, that's a very good question. I usually start with the drug company resources. So most of the drug companies that create these immunotherapies give out these little patient packs, which can be ordered through your melanoma nurse or your specialist nurse, or even just reach out to your endocrinologist and say, hey, I'd like a little bit more information. The other option is Eviq, is a website. It's a governing body for cancer treatment in New South Wales, and it has a patient information section, for each of the drugs. So you'll be able to open that, and that can show you common side effects and things to look for if you want a bit more information.
Okay, thank you. And I think there's something on there's also a resource on the Melanoma Institute Australia website and Cancer Council website. Really important question here. Is it safe to recommence immunotherapy if cancer comes back down the track? Now, even after ceasing treatment due to toxicity?
Yeah, and I think we touched upon that briefly with one of the previous questions. So especially with the endocrine side effects, we are happy to recommence treatment or even continue with treatment while these side effects occur. But this is only for the endocrine side effects.
Okay, right. And I remember you said, Stephanie, in your presentation that these side effects are permanent and these organs do not recover. Is that, and so there isn't any evidence of a pancreas coming back active again after immunotherapy?
I haven't seen it, but maybe Annabelle has some more experience in that field.
It's limited to case reports in the literature, which is around the world over the past sort of 10, 15 years. So it's very few. Sometimes the thyroid, sometimes it has only a period of underactivity, but that's, again, it's the minority of cases. So we'll watch and we'll monitor, and if you're eligible to come off hormone treatment, that's certainly something that we'd look into. But we presume from the outset it's going to be lifelong.
Right. Now I'm going to ask one more question, just because in the interest of time, we have gone over time, but if you're still with us, thank you for staying with us. These questions are really important. I'm just going to ask a question about numbness, and Carmel mentioned numbness, and I know it's common with some chemotherapy drugs. Could you say, is it also I'm assuming it is a side effect of the immunotherapy as well. Carmel shared that she'd had it. Tingling.
The tingling or the numbness, it's not very common. I would think in the case what Carmel described, that it was most likely caused by her deficiency in cortisol and not necessarily due to the immunotherapy. It can be a very rare side effect. So if we don't have another explanation for it, rule out other causes, then it could be due to the immunotherapy, but it's not something that is very commonly seen. Whereas in chemotherapy, we do see that a lot.
Lovely. Thank you so much. Now, there are some more questions, but I think in the interest of time, I'm going to close it there. There are lots of comments in the chat. There's some specific comments to really thank Carmel for sharing her story and how inspiring that was, Carmel, and we're all very grateful to you for being so authentic in sharing your story, and encouraging as well that you appear to be doing extremely well, and we're very happy about that. Our speakers, Stephanie, Aled, Annabelle and Carmel, thank you so much. Your expertise is highly valued and extremely important to our patients and our professionals alike. And we're extremely grateful to everybody that's attended this evening as well and given up also their time to contribute to this webinar. Thanks again to our incredible speakers. Thank you all for coming. I would just like to remind you all of two things. There is another webinar next week where we'll be talking about sentinel node lymph node biopsies, and we've got some great speakers for that session as well. And also when we close, which we're going to do in just a moment, there will be a survey pop up on the screen, which we'd love for you to complete. So I'd like to just once again say thank you to our incredible speakers for this evening. Thank you to Melanoma Institute Australia team for doing all of the work in the background, along with Natalie from Melanoma Patients Australia. And we'll look forward to seeing you next week. Thanks, everybody.